I will be joined by Andrea Martin, and we will be discussing differences between perimenopause and menopause. We'll be talking about the protective aspects of hormone therapy for those who are taking it, and then we'll discuss the differences between the different modalities of it, the patch versus the gel versus oral medication. So as Andrea logs in, we'll get her all therapy. Please don't hesitate to put them here in the link or in the chat box, and we'll get them answered. And there's a special discount code that we'll give at the very end of the talk, so stay tuned. Hi, Andrea.
Hi, hello.
Hello, how are you?
I'm just dandy. Thank you. How are you today?
I'm very well, thank you. It's so good to
Yay!
see you again.
You as well.
We've got a lot of questions to answer today.
Good. Let's do it. I'm ready.
All right. Let's start with, can you tell us the difference between perimenopause and when we should expect that miraculous phase of life to occur, and then menopause?
Yes, absolutely. So perimenopause is the time like leading up to menopause. So, and menopause, so that makes sense, it's this, it's literally one calendar day out of your life, technically. Menopause is 12 months since your last menstrual period. So if you've gone a full year without a period, you've now hit menopause. And then everything after that is postmenopause. So perimenopause is the time leading up to that, when we start to see little changes. Sometimes that can start in your late 30s, 40s. For some people, they get lucky. It's maybe only a year or two. In other people, it can be up to 10 years. But perimenopause is kind of a more chaotic time, I would say, where hormones are changing. So you'll see like progesterone levels kind of start to decrease, but estrogen, especially at first, can be very wonky. Like some days it's very high, other days it's very low, and that doesn't feel good. And then as you get closer in perimenopause to that day of menopause, 12 months into your last period, the estrogen levels just start to decline more. So sometimes the symptoms can actually be a little bit more severe in perimenopause. And then once you get to menopause, there's a little bit less volatility.
Less volatility. That sounds
Yes.
helpful.
Yes. Yes.
So today we're going to be discussing different modes of hormone replacement therapy. And hopefully you'll enlighten us on, do we start that during perimenopause or menopause? But one of the things that I wanted to highlight from a physical therapy standpoint is a concern that we have around when estrogen levels do start decline or they are acting wonky, we tend to see changes in bone mineral density. And that's why when we think of older women, we think of a risk of fractures and falls. Additionally, cognitive decline, onset of forgetfulness and memory issues, and just not being as sharp as they used to, and even dementia. And then additionally, heart health. The risk for women to experience stroke or heart attack escalates as those estrogen levels change as well. So hormone replacement therapy, as you pointed out in some of our previous talks, can be protective of bone health, heart health, and cognitive functioning. And that's really important when we think about our agency as human beings and we think about our independence and our ability to do the things that we want to do safely. And from a physical therapy standpoint, we take care of a lot of patients that have experienced hip fracture after a fall. And that is because the bone mineral density is not quite the same, and the balance can change as well, and so can the muscular strength. And we also know that after hip fracture, one's ability to stay independent can also decline, and we see higher rates of being put into assisted living and even mortality rates within 2 years after hip fracture. So it's really important from a general human being standpoint to think about the role that those hormones play in all of these different body functions and how protective hormone therapy is in replacing what we've lost to keep us safe and to keep us sharp so that we can be independent and enjoy that phase of our life.
Yeah, I talking about osteoporosis. I hopefully it's still live on my stories. I posted a video of Dr. Vonda Wright. She does a lot in the menopause space for the musculoskeletal system. She used to be a nurse and then she became a physician and does surgery on women with osteoporotic fractures. And I thought her kind of perspective on seeing the course that women go through, that she's the one that gets called in when they've broken a hip and and has to try and put their hip back together. And she said one of the most common things women always say to her is like, I wasn't always like this.
Mm.
And a lot of times you'll hear, like, I hear this from patients all the time, don't get old. Like, well, I don't have an option. There's only one alternative. But I think the point that they're trying to make is, do what you can to prevent this stuff. It's a very sobering place when you realize that you've kind of reached a point where, shoot, like it's too late. I can't necessarily do anything about this now. This is my reality. My whole life has changed here. But for those of us who are younger and have more time, it's nice to have that perspective to know that there are things we can do to prevent those changes in our body.
And the research now backs that up and it supports it.
Mhm. Yes, it do.
So, for hormone replacement therapy, we're talking about the replacement of those hormones that you just described, estrogen and progesterone.
Hmm.
And different people have different needs from that. And then there's different ways of utilizing it. So today we are talking about gel versus patch versus oral medications. And then we do have a discount code for those listening at the end of this. So please don't let me log out without telling what the code is. But
Okay, I will
can
not.
you break down what the differences are between these modalities and what is being delivered in these different types of hormone therapy?
Sure. So I think when it comes down to trying to figure out which choice is right for you, it comes down to two things: your past medical history and then your preferences. What works well for you. So there's basically two different categories. There's oral estrogen and then there's transdermal. And there's a couple different kinds of transdermal estrogen. So I think the most common one that people use is the patch. And so patch it looks like a little baby sticker that you put on your skin. It goes on like your lower abdomen or your like your upper butt area. Benefits to this is that it has a really steady state of medication release, which can be nice for people that again are trying to avoid that like volatility. If that really kind of worsens your symptoms, that can be helpful. With any kind of transdermal estrogen option, there's no increased risk of developing a blood clot.
And so
Um,
transdermal means through the
through
skin.
the skin.
And you're saying that this through the skin option leads to more stability in the hormones, which means more stability in how they're actually feeling.
Yeah, absolutely. And transdermal, it because you're not taking it by mouth, it's not getting processed through your liver.
Mm.
So you're not getting, that's kind of where that increased clotting proteins, things like that can increase your risk for blood clot. So we're avoiding that by just putting something directly on the skin, which is helpful. Um, Patches come in either like a once a week patch or a twice a week. The once a week ones are bigger, so if you feel like self-conscious about it, you don't want people knowing, seeing your patch or whatever, maybe you want to go for the twice a week. I also find sometimes the once a week patches start to fall off by the end of the week. Um, I will say it's that people are always like with the twice a week one, well, there's 7 days in a week, so it's a little awkward. It's like every 3.5 days that you change it. Um, and then I would say, as far as other kind of downsides to it, it is a patch, so it's kind of like a Band-Aid. Sometimes you can get that little like sticky residue from a Band-Aid. And then occasionally some people have allergies to the adhesive.
Mm.
But in general, that tends to be the most common one that people go for.
Mm.
So another transdermal option that you talked about is a gel. So it comes usually in like a little packet. You open it up, you squirt it out, and then you just kind of rub it onto your thigh.
Mm.
That is applied daily. For some people, that's a good thing because they're like, I can't remember to take something twice a week, but if I have to do it every day and it's part of my routine, I'm good to go. And then of course other people are like, I don't want to do this every day. So again, it's all about preference. Again, no increased risk of blood clots. One of the nice things I think about the gel is that you can really kind of target it to when your symptoms are worse. So if you know, oh my God, my night sweats are absolutely awful. I always feel worse at night. I can't sleep. You can apply it right before bed. And then that way you're getting kind of the greatest concentration when your symptoms are worse.
Mm.
Um, some of the downsides, some people just don't like dealing with the gel. You do have to wait for it to dry so it can absorb. Um, Obviously, don't want like pets or kids or anything touching it while it's drying. But overall, I think it works. It works pretty well. A lot of people like that as well. And then, so one thing I'll say, kind of, when you're looking at like real specifics of cholesterol, because
Mm.
different types of estrogen have different effects on cholesterol. So again, kind of grouping together all the transdermals, they're not going to make any of your cholesterol worse. So you don't ever have to worry about that. They can actually slightly decrease cholesterol levels, but they're definitely not going to make it worse. So I think that's helpful for
Mm.
people to know.
Absolutely.
Yeah. So then there's the pill or oral estrogen. So the great thing about that is it's easy. It's very easy to take a pill, just pop it in your mouth every day, especially if you're also taking progesterone pills. Everybody goes together, super easy. Um, the one thing that sometimes we don't want to give you a pill for is if you have an increased risk, anything that could put you at an increased risk of blood clot. So if you have high blood pressure, diabetes, things like that, probably not going to pick a pill for you. But I kind of want to put this in perspective because to me, you know, you hear like, oh, this type has an increased risk of blood clot, and it's kind of like, well, that sounds dangerous. That's not good. But I'm going to read you some numbers because when I heard these, it was like, oh, that's not that bad. So the average risk of say healthy person, and when I say healthy, meaning you don't have high blood pressure, diabetes, all those things. You don't have a history of blood clots. So someone who's not taking hormone therapy, just healthy random person is like risk of 2 or 3 in 10,000. The risk of taking a pill by mouth and developing a blood clot is 4 in 10,000. So that's like a very little boop up. Um, and birth control pills, which most people are not afraid of, that has like a 9 or 10, a risk of 9 or 10 in 10,000. So you're actually at a higher risk of birth control pills. So I think that helps to put it in perspective. I don't know why the narrative kind of got switched that like hormone therapy is scarier. And I'm not saying birth control pills are scary. They're great for most people, but the risk is actually lower with oral hormone therapy than it is for birth control pills. So, um,
We did
mhm.
have a question. It was, where's the best place to apply the gel? Currently applying to the forearm, but should she rotate or try other places? You had mentioned to describe placing it on the inner thigh. Are there other locations or is it only inner thigh or?
So when you look at like the package directions for like the most common name is called Divigel. Where they studied it was the thigh, and they say to rotate like each thigh, one night right thigh, one night left thigh. So that's where they studied it. So do I, is it possibly fine in other places? Sure, but that's where they studied it. So that's where they tell you to use it. Certainly that, we're gonna maybe possibly have different levels of absorption depending on where you apply it. I think, for the most part, I would say follow the package directions, but I do have patients sometimes that are like, I'm not sure if I'm absorbing this as well. Let me try another spot. Let's just see if I feel a difference. But yeah, that's where they studied it. So that's for those specifically. That's where they go.
Interesting. That's really good to know and nice that you can alternate between the two sides.
Yep. Though I would have a hard time being like, was last night the left thigh or the right thigh? It all just melds together.
Absolutely. And then how about, so you were talking about oral and you described that it was a lower risk of a cardiovascular incident, so like stroke or heart attack, lower risk than oral contraceptives or oral birth control. How
Mm-hmm.
about suppositories, that method of delivery?
So there is a vaginal ring. I have it somewhere here. Where is she? Out she comes. And this goes, so I always call this the set it and forget it method.
Mm.
So these can go in the vagina and then you change it out every 3 months. My package doesn't want to open, so we're forget that. I have a different version. Here's one. Here's what they look like. Kind of like it's squishy. You just squish it and put it in your vagina. So these are like, as far as risks and all that stuff, same category as transdermal. So as the patch, the gel, it's that you're absorbing the estrogen through your vagina, so you're not taking it by mouth. So again, better for people who have risk of blood clot, that type of thing. Um, and again, this really comes down to patient preference. Some people are like, oh, I don't want to deal with life. I can't remember to take stuff. Let me just pop this in, and in 3 months, my phone will remind me to change it. And then other people are like, I don't want that in my vagina. That feels weird. So it's all patient preference. And I see that somebody asked, is that systemic? And that's a good question because there's two kinds of rings. This fake one that I'm showing you is the one that's not systemic. So this is called the E string. That's only going to deliver estrogen to your vagina, your bladder, all that. The one that I can't get out of the package, but is there. It's called the fem ring, and that will deliver estrogen to both your vagina, bladder, all that, and your entire body. So that can be a little confusing.
And with those, does the patient leave it in when they're having intercourse or using a dilator, or do they remove it?
Again, patient preference. You
Okay.
certainly can. I've had plenty of people that are like, yep, nobody even notices it's in there. We just go on our way. And other people are like, I just don't want that in there.
Yeah.
There's enough people in this party.
The inn is full.
Yes.
We have a question about what about for someone who has a history of precancerous, I'm assuming cells in the breast?
So this is kind of a more nuanced area that's really patient dependent and dependent on kind of what your treatment options were at the time and uh, what kind of precancer, so all that type of stuff. So it's hard to give a general answer. I would say in the past, it's been very like, you have anything related to breast cancer, like absolutely no hormone therapy. As far as like systemic therapy goes, I think there's kind of a change coming. There's certainly people that with a long discussion, risk benefits, all that, will give systemic hormone therapy if you've had, some type of precancerous type thing. But then of course when it comes to vaginal estrogen, I don't care if you've had, precancerous cells or you have stage 4 breast cancer, vaginal estrogen is totally safe.
That's good to know.
Absolutely. Too many breast cancer patients are denied vaginal estrogen. It's a current and very pervasive pet peeve of mine. It just, there's no reason, and it makes me very upset for patients. So
I hear that from a lot of other menopause providers that have studied the literature and understand it and are working with those patients as well.
yeah,
So that's important for patients to understand, for people to understand, is that it's always a good idea to get another opinion from somebody who's actually trained in and certified in menopause as a specialty, because that person's going to be able to really thoroughly look at your history and explain what your options are.
yep. And we have over 5,500 studies that show that vaginal estrogen is safe for breast cancer patients, and it's still like, it's just hard to get clinicians to be aware of that. I can't really think of anything else that we've needed over 5,000 studies to prove a point, The
Yeah,
data is there. It's just sometimes people aren't listening. So I know it's very frustrating and confusing as a patient sometimes.
yeah, absolutely. Is there anything else that you'd like to share?
Let me think. The one other thing I think about that I mentioned with oral estrogen or taking a pill by mouth is the one other type of person I would not give it to if your triglycerides are already kind of high. I
Mm,
wouldn't probably wouldn't pick that for you because that's the one thing that the pill can increase is it could increase triglycerides a little bit. If you don't have high triglycerides, that's fine. You can take it, but don't want to potentially make that any worse.
absolutely. We got a question. So that's the suppository one, like estradiol. Yeah, let's talk about suppositories a little bit more because
Yeah.
some of them are coming more in like a tablet form or it's shaped a little bit like an
There's a
arrow.
lot of different types of suppositories. And again, this gets confusing. The only type of quote unquote suppository that is systemic, so whole body estrogen, was the ring that I can't open. Everything else that I'm going to talk about is just like it only affects your vagina. So there is, I mean, I guess I don't really don't think of the suppository, but there's cream, which is, that you put directly on the vagina. And then there's also things that look like little tiny pills, basically, that go inside the vagina and melt. And there's different forms of that. Um, who else am I forgetting? I have I have little samples of everybody. Like one of them has googly eyes because everything has googly eyes in it. But like this is the little applicator, and you could see the little pills in there. Yours will not come with little eyeballs staring at you, but you
If only.
I know, if only. I don't know if that would make it better or worse, but you just put this in the vagina and then hang on, I'm gonna shoot it at you. You press the button. I don't think it went on camera, but it shoots out. And that just inserts the little suppository into your vagina. So it's a little teeny tiny pill. So it's easy. Easy peasy.
Easy peasy. And some
We're
of
gonna
them are shaped a little bit like a torpedo. And they can come in
Yes,
and be placed into the vaginal canal. They're very easy to place.
yes.
They glide right in.
I know. See. Let's see if we can get these open. Oh, this one's pre-opened. So like this one, yeah.
Perfect.
Torpedo.
Torpedo.
Pointy end goes in first. That feels a little bit nicer.
Yes.
So yeah, we got all kinds of shapes and sizes and fun things to play around with. People all get very nervous, like, which one do I pick? And I'm like, we pick the one that speaks to you the most. And if you try it and you're like, this isn't what I thought, we hop to something else. So always it's flexible. I see somebody ask, is the suppository used twice weekly like the estrogen cream? Yes, so googly eyes here. Yes, you use it every night for 2 weeks when you're first starting, and then after that, it's twice a week. Um, this one is different. This product, that's like the torpedo one because that is DHEA, so it makes estrogen and testosterone. That's a nightly medication. Though I've had some people use it a little bit less and do fine. And then of course the ring you change every 3 months.
Sure.
I think I have
Is
anything else.
is one form better for prevention of genitourinary symptoms of menopause, GSM, or is it whatever you prefer? So she's talking about prevention.
Mm-hmm. Yeah. I don't know if I'd say one is necessarily better than the other. I think the one that's best is the one that you'll actually use and you're happy to use and that you're comfortable using. Um, it- it's really funny and it's patient dependent. Like I've had some people that love the cream because they're like, I can put it exactly where I need it around the opening and that feels great. And other people are like, ew, cream, that feels gross. I don't want to do this. So for that person, cream's not the answer. They're not going to want to use it. Some people think the little pill that goes inside, oh, it's super easy, no mess, I love it. And other people are like, yeah, but I don't feel as much of like the meltiness, and that doesn't feel as soothing. So one person's, ick is another person's
Yum.
whatever that word is. Yeah, thank you. The other thing, the opposite of ick. But yeah, they all work really well.
Other questions for people that
We
are
got good
joining us?
questions
We
today.
did get good questions
I
today.
know. We like being challenged.
That's right.
And don't forget the code.
Ah, the code. Okay. For those that have watched all the way to the end, we have a discount code for 10% off all of our tools at intimaterose.com. The code is PATCH, PATCH. Patch. It's good for 1 week. Additionally, we have additional information that's going to be in the body of this post. If you want more information about hormone replacement therapy, just put info in the comments here and we will send you more information. We are always here to answer your questions. Andrea is just a wealth of knowledge. Every day I'm thankful for Andrea. And we are going to be, for our providers, we have a webinar next week on Thursday where you're going to be helping to educate other providers about what to look for in our perimenopausal patients. And that is free. So if you are in our pelvic health network, look for the link for that meeting. And additionally, we will be back again live in 2 weeks. Topic will be on hormone replacement therapy. We'll probably be covering a little bit more introductory information, dispelling more myths, and then we are also going to be discussing breast tenderness. So we have that to look forward to. So thank you so much, Andrea. I appreciate your time and your expertise, and I look forward to hearing all that you have to say for our providers next week, and we'll be back here for Instagram Live in 2 weeks.
Thank you very much.
Bye, applicator. Thank you for being here as well.
Bye.
Thank you for your time and expertise.
We shouldn't be.
Oh,
We shouldn't have a platform.
absolutely. Mandy and Andy talk vaginas. We deserve all the microphones. So does Googly Eyes.
Stuff. Thank you, everyone.
Thank you. We'll see you soon.